All right, we're live,
Oh,
and
great.
I'm so happy to be here. Sorry for those who have been watching or waiting. We're a little bit late because we're having some technical issues, but I'm glad to be here with the awesome Dr. Moustafa Youssef. But before we go ahead, let me quickly introduce myself. I'm Dr. Olabintan of Living Spring Family Medical Center here in Mansfield, Texas, where we help people live long and well. And so we're having gut talks with the GI doc today. So thank you, Dr. Youssef, for coming.
Thank you. I'm so excited. Thank you for having me.
All right, awesome. So, for the sake of our viewers who are watching live and who will watch this on replay, can you please kindly introduce yourself? Who are you and what do you do?
Of course. Thank you for having me again. My name is Dr. Moustafa Youssef. I am board certified in internal medicine and gastroenterology, and my main area of practice is basically gut health, gastroenterology. I joined Digestive Health Associates of Texas back in 2014, and I have been practicing medicine for the past 15 years. I have been in the Fort Worth and Mansfield area for the past 7 years, and I really enjoy taking care of my patients and help them to continue to have a healthy gut and a healthy digestive system.
Awesome. You're good at what
Thank
you
you.
do, so that's great. So my next question is for those who are watching: why do you do what you do? Like why GI? What was the story behind that?
Well, that's a very interesting question. So, one of the things that I really enjoy is spending time with my patients, and also I really like taking care of them, not just physically but also mentally. Back when I was in medical school, I actually went to medical school back in Egypt, where we had a significant pandemic of liver disease. This is when I was introduced to the GI field and the liver field, and saw how preventative health would make a great difference in these patients' lives, especially just teaching them basic hygiene that would prevent them from encountering hepatitis C. And from there, I also enjoyed doing procedures on the surgical side, and I found the GI field to be the best of both worlds, that I can still be an internist and spend time with my patient, and also can help them with the need procedures, and enjoy the technical part of medicine as well.
All right, awesome. Good to know. Good to know.
Thank you.
So my next question is let's talk prevention. So I'm very big about prevention. Like what can we do to prevent things from happening down the line? So are there really ways to kind of keep your gut healthy? Like would you say generally speaking, are there ways? And if so, what are these ways?
Of course. So this is right up in our alley. I think prevention is one of the essence of medicine. I like to, in my field, and I think in your field as well, we see a great proportion of healthy individuals rather than seeing patients in the preventative care. I come to your clinic to stay healthy and make sure that I'm healthy.
Right.
I go to my gastroenterologist to make sure that the preventative part of my digestive system is in a check. The talking prevention have multiple aspects in the digestive health. It start really from home. What do I eat? What do I drink? How much exercise I do? What we are over the past 10 years, we have learned a lot about the neurogut axis and how our physical health affect not only our mental health but also affect our digestive health, our heart health. Diet and exercise play a very important role, not only in our physical activity and weight control, but also play a significant role on our digestive health, in our focus, in our concentration. And it's really amazing to see that very few things that we can do on a daily basis can significantly impact our longevity and our digestive health. And there is multiple points of discussion here in terms of prevention. Like, a lot of my patients would come to see me because they start having some, GI upset for one reason or the other, and it always starts with a trigger, and that trigger could be as simple as changing the environment. So not necessarily that I got sick and then I start having some GI symptoms or abdominal pain or nausea. Not necessarily. I just travel for leisure and then just being in a different environment that my body lives at, and then now I have GI symptoms that I never experienced. Or I was, experimenting with a new diet that kind of, I thought that would be healthy, and once I start on that diet, by week 2, I start having diarrhea, or I start, significantly having nausea or anorexia, and then going to the pathological side. Patients would, encounter an infection and take an antibiotic, and then it starts affecting their digestive system. And all these are basically related to our gut microbiota, to our digestive or our GI system motility, and also our stress response. So as simple as making sure when you travel, you keep up with drinking clean water, taking probiotics, and keeping up with fibers would prevent multiple complication coming back home. Or I'm telling my patients, now we know that you're sensitive, or your digestive health are sensitive to antibiotics. Make sure once you start an antibiotic for one reason or another, and all of us will need antibiotic at some point, to start a probiotic along with it, and take probiotics at least for 2 to 4 weeks after finishing a course of antibiotic, to kind of replenish the bacteria flora. And from that's just the basic day-to-day things. And then if we talk about preventative services that we have in the GI field, starting with colon cancer screening, and how we can detect small tumors or small lesions in the colon and remove them before they progress into a cancer. And it is very interesting field at this point, that we are finding more and more precancerous and colon cancer at younger patients than before, and there is multiple reasons for that, and some of them related to our lifestyle, our diet, our lack of exercise, and also some of our habits.
You said a whole lot, Doc, and I want to break it down some. So you
Sure.
mentioned a lot of things as far as preventive. Number one, diet and exercise play a role. Exercise is actually important for your gut. I find a lot of patients tell me that they're able to have more regular bowel movements when they exercise. When they stop exercising, of course, then it becomes an issue. Antibiotic
Sure.
use, important to, restore the normal flora, the normal bacteria
Sure.
that helps your stomach or helps your gut with digesting food. So taking probiotics. Now, all of these are advices. They're advice for you. Of course, we expect you to have conversations with your primary care doctor and your GI specialist as needed, so that they can give you individualized care. But these are speaking in general. And of course, preventive measures like screening for colon cancer, sooner than later now. We find out over the last few years, right? And we'll talk more about that later. But these are very, very important things to note. You also mentioned fiber, fruits and veggies. Really, 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 really important. So
Important, right?
I didn't tell him to say that, but it's funny how it's a recurring thing. What you eat and your exercise level affects every organ of your body. All right, awesome. So the next question I have for you, Doc, what are the 3 most common issues you tend to see? We're curious. Like, what? Yeah.
Sure. So other than prevention, which we will talk about, like colonoscopy screening, that I see a significant number of patients for preventive service, one of the common complaints that I see is the complaints of acid reflux and dyspepsia. That's number one. Number two, changes in the bowel habits in general. Patients that have regular bowel movement start having diarrhea, or the opposite. Patient have constipation or abdominal pain, or a syndrome where they have multiple GI symptoms, which sometimes lead to irritable bowel syndrome. And then when the third kind of common pathology, or this is one of the things that I'm very interested in, is the field of inflammatory bowel diseases, which
Mm.
is ulcerative colitis and Crohn's disease. These are these are actually autoimmune diseases that have kind of two components. Part of it is kind of genetic, and the other part is environmental. And these patients could present with brand new symptoms of abdominal pain, bleeding, diarrhea, weight loss, stuff like that. And it could happen at any age. I've seen patients at the age of 18 when they transition care from their pediatric gastroenterologist all the way to patient in their 60s, and they start having symptoms of inflammatory bowel disease.
Oh wow. Yeah, that's a big one. That's a major one.
Of course.
That's interesting. Now, can we talk briefly about IBS, irritable bowel syndrome?
Of course.
And I know this is a little bit of a complicated.
It's a bigger topic, but it is very interesting. We have learned significantly over the past few years about irritable bowel syndrome. Back in the days when we used to do all the diagnostic studies and try to make sure that the patient does not have any other disease, we used to say, well, I'm not sure what's going on. I don't see any cancer. I don't see inflammatory bowel disease. I don't see acid reflux. I'm not sure what's going on. It's probably in your head, and you walk away. And that was, very, unsatisfying for physicians and very stressful for patients because they have real symptoms and they can't figure out what causes it. That was, as I mentioned, years ago. Now we learned a lot of information that lead us to understand our patient's symptoms better and treat them better. The full disclaimer, I have to say that diagnosis of irritable bowel syndrome is very important to be done after a thorough evaluation by a gastroenterologist, because diagnosis of irritable bowel syndrome is a diagnosis of exclusion. So I have seen patients with multiple GI diseases that could be curable or treatable that was labeled irritable bowel syndrome and never had a full GI evaluation. And these conditions could be anywhere from just an infection in the stomach like Helicobacter pylori to gluten sensitivity like celiac disease, to malabsorption syndrome, to an allergy condition, to even colon cancer. And they saw that their change in their bowel habits or being constipated or the stool change, that this is irritable bowel syndrome just by reading over the internet. So irritable bowel syndrome is a diagnosis of exclusion. And irritable bowel syndrome, as the word says, syndrome, it is multiple symptoms, and every group of patients present differently. I have patients that have abdominal pain, bloating, or dyspepsia associated with diarrhea. I have some patients that have their main symptom is constipation. I have some patients that have alternate diarrhea and constipation with abdominal cramping. I have patients that their main symptoms are only related to specific type of food that they eat. And I have patients that have irritable bowel syndrome symptoms that are related to pretty much all what they eat. And even the triggers of irritable bowel syndrome are different. And then we can even talk more that irritable bowel syndromes in different patients mean different things. There is post-infectious irritable bowel syndrome. That's the simplest form, which is basically something that's short-term, reversible, and patient does not have to live with for the rest of their life. And the treatment for it is very simple. And usually it happens after, an infectious diarrhea, or patient have a traveler's diarrhea or some sort of an impact that affected the patient, and then they start having symptoms. So again, irritable bowel syndrome at this point is really much easier disease to diagnose, and also much easier disease to explain to patients. And I have a lot of patients that with a very simple changes in their diet, in the supplement that they take, in the timing of their other regular medicine that they take, and their irritable bowel syndrome are pretty much cured, and they have a normal, healthy lifestyle. Stress play a major role in our lives, not just in our digestive health, in our lives. Just think about, I always explain that to some of my patients. Just think about that you have a job interview, or you have a test the coming morning. Would some of us have some stomach upset? Sure. Some of us have headache. Sure. Some of us have insomnia. Sure. You can't sleep. Sure. Some of us have diarrhea. Sure. And you can count multiple of these. This is just that you are thinking or worried or kind of being stressed about something, that you have an interview or have a test, and then you're nervous. That's the bottom line. And then you start having some of these symptoms, either headache, or some people have cough but also have GI symptoms. And based on that, we can also treat some of these symptoms the same way that we treat stress, and then these symptoms go away.
It's so interesting you say that. I say that because sometimes, I'll be honest, I get nervous when I come on the lives. And so
we all do. We all do. It just how different how we present to different types of stressors are fascinating. And this is why it is not one thing fits all. It is just a really kind of a patient by patient approach that you take care in your clinic, and you see where are we at, what we need to do, and then take it to the next level.
And there's something that you said that's very important. Irritable bowel syndrome was something that was always poo-pooed as, oh, it's just, you, and it may not be real, or it's something that you're just causing yourself. And it can be frustrating for the patient.
Right.
But I like that you emphasize that it is a diagnosis of exclusion, meaning a good workup is necessary. So please encourage, of course, conversation with your primary care doctor. And sometimes you have to encourage your doctor to, send you to a GI doctor for a thorough workup. So that's very, very helpful. Thank you so much, Doc.
That's great. Sure, no problem.
All right.
I think the other, larger percentage of patients that I see over the past few years is actually a patient with acid reflux or heartburn. We have made breakthrough in this field, the foregut disease, to the point that we have now a very sophisticated diagnostic testing that can tell us exactly where the heartburn is coming from, how we can fix it, and how much damage the patient had, and how can we reverse it. There is an initiative, and this is why I brought it up. There's an initiative that we have here in the Mansfield area that I think is very unique to the DFW area, which is the Heartburn Center. So if we got a few minutes, I'm happy to explain what's the Heartburn Center and what's entailed.
Oh yes, please go ahead.
Sure. So acid reflux or heartburn, just in a nutshell, so all our audience would hear about and know what is heartburn. Some of us would, after eating specific types of meals, would have a burning sensation or regurgitation. Some of us would have, when they go lie down, they start feeling that the acid in their stomach or the content in their stomach start regurgitating. We have patients that wakes up in the morning with sore throat or metallic taste in their mouth. We have patients that have no symptom, and they go to their dentist and they tell them, I think you have really bad acid reflux. It is really affecting the enamel of your teeth. Or patients have consistently having allergy symptoms or cough that cannot go away, and they go to their ear, nose, and throat doctor, and they do a laryngoscope. They look inside their throat and say, oh, you have bad laryngopharyngeal reflux, or you have reflux that comes into your throat. And they ask, reflux from where? So this is basically a regurgitation of the stomach content, which the top of the stomach content would be the acid, the hydrochloric acid, that being secreted by the stomach to help digest part of the food, and also to disinfect the food from bacteria or any toxins that's in it. And if the acid is secreted in excess, or there is a dysfunction at the valve at the lower end of the esophagus that supposedly keeping the esophagus closed, so the stomach food and content would not be regurgitating or coming back into the esophagus and causing this heartburn symptoms. The stomach, inner lining of the stomach, which is the food sac, the organ that kind of grinds the food before it moves it into the small bowel for the digestion and absorption process, is tolerant to the acid. But the esophagus inner lining are not like the stomach. It's very sensitive to acid, and if we have constant exposure to acid in the esophagus and we're just living with it or not taking care of it, it could predispose to serious complication, not just esophagitis and GI bleeding, but also Barrett's esophagus and even esophageal cancer. So patients that have heartburn should take that seriously and try to talk to the primary doctor or see a GI doctor to try to help with that. And sometimes that the heartburn symptom or acid reflux symptom could be as simple as some lifestyle modification, changing the timing of eating, changing the dietary habits, or kind of limiting some of the habits that we have, like excessive alcohol drinking or smoking, could cure the heartburn significantly. And also sometimes we find out that patient could have anatomical problems that if we fix, then their acid reflux will go away. And in between these two, there's also significant number of medications that we could use to try to control the acid reflux. Can you hear me? I'm sorry.
Okay, I can hear you. Froze for a little second.
Okay. Can you hear me now?
I can hear you. You froze a little bit. It was a good freeze, though. I can hear you.
Let me see. I can't hear you.
You can't hear me? All right, let me mute and then let me mute.
I think you're muted.
Can you hear me now? I can hear you. Let me see.
Can you hear me now?
I can hear you.
Okay, so I'm going to start talking, and I can't hear you, but I'm gonna get the Heartburn Center, but I see that your mic is muted. I don't know.
Huh. Let me see. All right, go ahead. Go ahead. I'll text you.
Okay. I'm going to start talking. Okay,
I will text you. Okay.
All right, sounds good. So over the past few years, the field of the foregut have multiple advances that help us diagnose patients with heartburn to a significant accuracy, that if we exactly know how significant is the acid reflux and how can we treat it. And that include multiple testings that are very simple that can tell us if the patient have a weak valve at the lower end of the esophagus that causes the acid reflux, or they have a hernia, a hiatal hernia, which could be the cause and the driver of severe acid reflux. And these two conditions could be treated by surgery, could be treated by simple procedures like TIF procedures that I perform, or also by medication. It all depends on what's the function. We used to, when patients have acid reflux in the past that we didn't know we didn't know how bad it is, or we didn't have these testing, we used to send them to surgery, and then they have surgery, and then 50% of the time patient feel better, and 50% patient would have the same symptom after surgery, because we were not able to diagnose accurately. At this point, we have all the testing we need. And from there, we had a coalition, the gastroenterologist in the Mansfield area and the surgeon in the Mansfield area. And we had the Methodist Mansfield Heartburn Treatment Center, where we are able to have all the cutting edge testing, including upper endoscopy to look at the anatomy and diagnose if the patient have a hernia or have an infection or have an ulcer. Esophageal manometry, which is a test to look at the muscle function of the esophagus. Patients that have heartburn for many years, sometimes it caused damage in their muscles in their esophagus. So these patients would have trouble swallowing, not only just heartburn, but also trouble swallowing. And these patients need specific treatment, because if they have a regular heartburn surgery, they could have more trouble swallowing afterward. And then there is an accurate test to test the pH, or the amount of acid that the stomach secrete, and then tells us exactly, is this patient having acid reflux at nighttime or daytime or all the time? Because there is an equivalent of irritable bowel syndrome, is actually called non-acid reflux syndrome, where the patient feel acid reflux, but they don't have acid regurgitate. And the only way to know that is to actually test their amount of acid in the esophagus by the pH monitoring. And we have that multidisciplinary approach, that any patient that comes for the Heartburn Treatment Center, see myself, see another, or see the surgeon first, they will go through the same workup. We will discuss the case in a multidisciplinary fashion before we decide if they need surgery or they need medical management, and then we move forward with that. And it always starts with prevention. It always starts with having a discussion with the patient. What happens that make you start having heartburn? One of the main things is that I stopped exercising and I gained weight, or I have a baby and then I gained 10 pounds, and then I start having acid reflux. These are very subtle changes that could cause acid reflux, and they're easily reversible. Once we know what was the trigger, we can walk it back. But also lifestyle is very important. A lot of us work long hours, like me and you. We come back home late, and then it's time for dinner, and then it's time to go to bed. And if you eat and go to bed and you have weak valves, then acid reflux would trigger, and then you would have symptoms overnight or in the morning. So changing the timing of meals are also very helpful. Making the larger meal of the day, early, like lunch or a little earlier, and then having a light dinner would make a big difference. The major food elements that trigger acid reflux that I always talk about with my patient, sometimes I call it the evil five. They're not evil if everything was moderation, but chocolate, caffeine, nicotine, alcohol, marinara sauce, all these elements stimulate the stomach to increase acid secretion. So if I have heartburn and I, go to an Italian restaurant, for example, and have all these menu items, I'm sure I'm going to pay the price at the end of the day. But again, with treatment, you could enjoy all these food elements or these items, but with moderation early in the day.
Okay. I'm going to send you a text. Great points. I want us to go and talk about colon cancer before we're done. So I've sent you a text. Let's talk colon cancer. Some people are afraid of the procedure. How do you advise? Okay, I've had patients tell me they get a little nervous about doing the colonoscopy. How do you advise?
Okay, colon cancer. It is one of the near and dear topics to most of the gastroenterologists. Why? Because it is one of the preventative procedure. I can count how many bad days or sad days when I have a patient that I diagnosed with colon cancer that would have been preventable if we have done appropriate screening. Colon cancer is like any cancer. It starts, for the most part, in most patients with a benign tumor that grow at the inner lining of the colon. We call it a polyp if you heard it before. We call it a little tumor. We call it an adenoma. These are small growth or small nodules that grow in the inner lining of the colon, and over time it could progress into cancer. The process of a polyp or a tumor, a process of a polyp development could take a few months to a few years, but a polyp getting larger and growing into a cancer could be over a span of 10 years. That's in general population, but if a patient or a family have a family history of colon cancer, then the process becomes much faster, and this is why we have different recommendation for patients with family history of colon cancer. Because how many colon polyps and colon cancer we have been diagnosing, the U.S. task force came back and recommended a new age for colonoscopy screening. Colonoscopy screening used to be indicated at age 50 for general public and age 45 for Hispanic and African American. Last year, the newer recommendation recommended colon cancer screening for general public at age 45. And it is very important to explain why it is important to get a colonoscopy screen. Number one, the procedure at this state and age is a very simple procedure. It is not a surgery. Yes, it is. We all kind of think about it's an invasive procedure. Colonoscopy is different than going to an OR and being under general anesthesia and have to stay in the hospital. None of that would apply for a standard screening colonoscopy. It is kind of moderate sedation to monitored anesthesia care, where patients would receive sedation that would make them asleep, like in a dream. And then once we're done with the procedure, they wake up right away. So patient will be asleep, breathing on their own during the procedure, but they will not remember anything about the procedure as soon as they wake up. The other hard part that people think about that, I cannot eat for 24 hours before the procedure. And I have to drink something that doesn't taste good and it will drain me or something like that. So we'll break it down by bits and pieces. A lot of us have been doing now intermittent fasting and water fast and liquid fast. So you're not going to be fasting completely, the day before your procedure, and it depends on what time of your procedure. Let's say that your procedure is first thing in the morning. And the day before the procedure, you need to be on clear liquid diet. And the main reason for that is with the new advances in the endoscopy field, where the tube that we use to look for these polyps, it's called a colonoscope. It's just a very flexible tube with a shine of a light and a camera. It has ultra high definition camera and light, and we're able to detect very superficial small polyps that we were not used to see before. But the only way for us to see that, we need the inner lining of the colon to be clear. If the inner lining of the colon is not clear, or the patient did not drink a bowel prep and become on a liquid diet for that day, then it becomes harder to pick up these very small polyps. And my goal is to have all my patients have their screening and have no polyp and come back in 10 years.
Right.
But if I don't have that good cleanup of my colon, then your doctor is not going to be comfortable to bring you back in 10 years, and you probably will have to come back sooner because your colon are not clear. But again, it is at this stage, it is very simple. The day before the procedure, you're going to be in clear liquid, which could be, it's very, it includes jello, juice, popsicle, chicken broth, beef broth, Gatorade, tea, coffee, soda, water. It is just liquid diet. And then the new medications that we use to cleanse the bowels that are FDA approved are much better than the gallon of drinks that tastes like, my patient comes and say, am I going to drink the liquid antifreeze? And I said, no, there's no liquid antifreeze. So we have now pills, and we have small volume liquid, which is powder that you mix in 8 ounces of water, 10 ounces of water. It's also, we have different preparations that are flavored, and you can also flavor your bowel prep. And we usually discuss the bowel prep selection or option with patient by patient, because some patients have kidney disease that we need to specify a specific bowel prep. Some patients have intolerance to large volume of liquid, so we give them the pills. But this is again one-on-one cases. But it's either you're going to drink 2 cups of liquid 6 hours apart, or you're going to have a bunch of pills at one time and 6 hours later you're doing the other bunch of pills. And that basically is just like going through a cleanse. It will flush your system, and then the day of the procedure is going to be actually a simple day. You feel lighter. You come in the morning. You have a nap. You wake up thinking that we haven't even started. I tell all my patients that, and they cannot believe it. This is what happened. They wake up, say, "Oh, are we already done?" Yes. And there is multiple ways. I have to say that there is multiple ways to screen for colon cancer. It's not just colonoscopy, and it is important to again individualize that by patient and discuss this. Why? Because there is FDA approved modalities, including stool testing, some blood testing, and there is also flexible sigmoidoscopy, and there's some imaging that could be done. But why we all talk about gold standard screening colonoscopy, and all the society endorses it at the first line and the gold standard, because number one, it is not just a diagnostic. When you do a colonoscopy screening and you have a polyp or a tumor or a cancer, I'm able to remove it right then, so you don't have to have 2 procedures or 2 tests for the same thing. Number two, it has the highest accuracy of evaluating the entire colon, because you are seeing it as we are doing the colonoscopy. We're seeing every inch of the colon and evaluating it clearly. And this is why it has the longest interval. If you have a normal colonoscopy, you come back in 10 years, compared to some of the stool testing 3 years, or some of the other stool testing every year or every 3 years if you have a flexible sigmoidoscopy or a barium enema. And then there's also other benefits of having a colonoscopy, at the beginning of at the recommended age of 45 years old, because as I mentioned earlier, that it takes possibly 5 to 10 years for polyp to turn into a cancer. And our problem that we're finding more early onset colon polyps at ages younger than 45. So, and I'm seeing more advanced adenoma and pre-cancer and maybe early cancers in patient at age 50. So this is where the newer recommendation at age 45 of getting a colonoscopy comes from.
Wow. Thank you so much. Just a lot of information that has been very, very useful. So people are encouraged to screen for colon cancer.
Thank you so much. Just a lot of information that has been very, very useful.
And I'm going to send you a question now. Where can people find you? Where can people find you? They're saying, I want to meet this GI doc.
Sure.
It's awesome. Where can we find you, doc?
All right, I got your question. Where can patient find me?
Yes.
So I am located locally here in Mansfield. My primary main office is located across the street from Methodist Mansfield Hospital. The address is 647 North Miller Road. And our new office have a big logo called GI Alliance. And this is where our clinic is, and we have a surgery center as well that we perform some colonoscopy and endoscopy at. And it is right across the street from Methodist Mansfield Hospital on Broad Street and right next to Walgreens.
All right, awesome. It was an honor having you. Thank you so much for coming. At this time, we're going to wrap up and say we're done. This is the voice of Dr. Olabintan, Living Spring Family Medical Center. Thank you all for watching. Please share, forward this information with people who will find this useful. And if you or anyone you know is looking for an awesome, a passionate and thorough family physician in the Mansfield area, I am she. Thank you so much, Doc. It was nice seeing you.
Thank you.
All right. Bye.
Thank you for having me, and looking forward to take care of our Mansfield and neighboring community. Thanks for having me.
Definitely.